Good afternoon. My name is Imaan, and I'm a incoming fifth-year student, and I'll be presenting on my literature review on understanding the burden, challenges of diagnosis, treatment, and prognosis of cholangiocarcinoma. So, cholangiocarcinomas are rare tumors that develop from the biliary epithelium, and 95% are classified as adenocarcinomas. They account for about 3% of all gastrointestinal malignancies, and they are the second most common primary liver tumor after hepatocellular carcinomas. So they're classified according to the site of lesion within the liver into intrahepatic cholangiocarcinoma, perihilar, and distal cholangiocarcinoma. And the most common type is the intrahepatic cholangiocarcinoma. Its prevalence varies geographically, and this map here is from the World Cholangiocarcinoma Foundation, and you can see that the most prevalent region is China and countries of Southeast Asia, and also that there's not much data in Africa about cholangiocarcinoma, and that's why the area is grayed out. It's slightly more common in males. In USA, the highest incidence is in Asians and in Hispanics. So the trends have been changing in incidence and mortality rates in the last 2 decades. There has been a 165% increase in the incidence of intrahepatic cholangiocarcinoma in USA in the last 30 years. The overall age standardized mortality rates have also been rising in other developed countries in Europe, in South America, and in Australia. And the incidence of extrahepatic cholangiocarcinoma has increased by 14% in the USA in the last 2 decades. In USA, the mortality rates have increased, especially for the Black and Asian populations, by more than 40%. And WHO reports global mortality rates for cholangiocarcinoma having increased between 2010 and 2010. So these are the risk factors for cholangiocarcinoma. They include liver flukes, primary sclerosing cholangitis, gallstones, obesity, hepatitis, germline mutations, and diabetes. And liver flukes are major causes in Asia, and they have been recognized as grade 1 oncogenes according to WHO. They affect up to 56 million people globally, and out of these 56 million people, 12.5 million are from China, and the prevalence of cholangiocarcinoma among the infected people is 14%. In Africa, the most prevalent liver flukes are fasciola hepatica and gigantica, although the association between fascioliasis and cholangiocarcinoma is not very clear, but some animal studies show an association with liver cancer, and it has been considered a neglected tropical disease by WHO, and it is expected to rise due to the prevalence is expected to rise due to global warming. Primary sclerosing cholangitis is a major cause of cholangiocarcinoma in the developed world, and it increases the risk of cholangiocarcinoma by 9% after 10 years following diagnosis. Cholangiocarcinoma presents at a younger age in these people at about 30 to 50 years. And the prevalence of cholangiocarcinoma in people suffering from primary sclerosing cholangitis is 40%. 14 to 18% of HIV deaths are caused by liver disease, and HIV/AIDS can cause cholangiocarcinoma in various ways, one of them being opportunistic infections that have a biliary tropism. They cause recurrent and chronic cholangitis, which is a precursor of cholangiocarcinoma through the hyperplasia, dysplasia, carcinoma sequence, and also through AIDS cholangiopathy, acalculous cholecystitis, and heart toxicity. So what is causing the change in trends? It could be due to increased alcohol and cigarette smoking, increased prevalence of obesity, diabetes, and metabolic syndrome, improved diagnosis and disease surveillance, increased prevalence of liver fluke infections due to environmental factors such as global warming, increased incidence of hepatitis B and C, and HIV and AIDS. So these are the average ages at which cholangiocarcinoma is diagnosed, and it normally presents with non-specific symptoms of liver disease such as jaundice, pale stool and weight loss, and abdominal pain, and it's diagnosed using imaging modalities such as ultrasound, CT scans, and ERCP. So these are the staging methods used to stage for prognostication and to check for resectability of the disease. That's AJCC staging and Bismuth-Collett classification. So surgery is the mainstay of treatment, and 10% are diagnosed early enough for surgical resection, and the majority are diagnosed when the disease is at advanced stages. So surgical resection is not possible, and the mainstay of treatment will be the main form of treatment will be chemotherapy. But unfortunately, these chemotherapeutic drugs are inaccessible and expensive in middle and low income countries. So cholangiocarcinomas have a high mortality rate. Following complete resection, the 5-year survival rate for both intrahepatic and perihilar cholangiocarcinomas ranges between 30 to 40%. The median survival time for patients with inoperable tumors is reported to be between 12 and 15 months. Mortality rates for extrahepatic cholangiocarcinoma have been dropping for most countries, while those for intrahepatic cholangiocarcinoma are rising. And the reason why the extrahepatic cholangiocarcinoma rates could be dropping, mortality rates could be dropping, is because of the increased risks of cystectomies. And the prognosis for the condition varies according to the stages of malignancy. So in conclusion, the global incidence and mortality rates of cholangiocarcinomas have exhibited dynamic trends. However, it remains uncertain whether the corresponding patterns are the same in Kenya and in other countries in Africa. It is imperative to conduct further research in Kenya, as numerous factors associated with this condition are prevalent in the environment. These are my references. Thank you.